Welcome to the series where I review the 2025 AACE Consensus Statement on the algorithm for the evaluation and treatment of adults with obesity or adiposity-based chronic disease. This is Endo in a Bite, where I break down complex concepts into bite-sized pieces you can actually remember. Today we will move from the anthropometric component into the clinical component of diagnosis, because this is where excess adiposity is evaluated as a disease process rather than a weight category. Up to this point, anthropometric measures such as body mass index, waist circumference, and fat distribution have helped identify excess adiposity and cardiometabolic risk. The clinical component answers a different question: what disease burden is already present and how severe is it? The AACE framework defines obesity as adiposity-based chronic disease. This model requires evaluation of obesity-related diseases and complications. The goal is to determine whether excess adiposity is already causing clinical disease and to what extent. The first step is to evaluate for the presence and severity of obesity-related diseases and complications. This begins with a focused medical history and an obesity-focused history, a targeted review of systems, a physical examination, and basic laboratory testing. The purpose is not simply to list comorbidities, but to determine whether adiposity is driving disease. Once this evaluation is complete, the next step is to stage adiposity-based chronic disease. Staging is not based on body mass index. It is based entirely on the presence and severity of obesity-related diseases and complications. Stage 1 refers to patients with excess adiposity, but no known cardiometabolic, biomechanical, or other obesity-related diseases. These patients do not yet have complications, but they do carry an increased risk of developing obesity-related disease in the future. Stage 2 is defined by the presence of at least one mild to moderate obesity-related disease or complication. This may include early cardiometabolic disease, early mechanical complications, or other obesity-associated conditions that are present but not severe. Stage 3 is defined by the presence of at least one severe obesity-related disease or complication. In these patients, excess adiposity is clearly driving advanced disease and morbidity. While staging disease, clinicians must also evaluate contributing and modifying factors that influence both diagnosis and management. One important consideration is medication-induced weight gain. These medications should be reviewed carefully and modified or replaced when possible. Clinicians should also consider secondary medical causes of weight gain, including endocrine disorders and other medical conditions. Focused biochemical or dynamic testing should be performed when there is clinical suspicion. This is not routine screening, but targeted evaluation based on the clinical presentation. In patients with features suggestive of genetic or syndromic obesity, such as early-onset obesity, severe hyperphagia, or characteristic physical findings, genetic testing should be considered. Psychological factors are also central to care. Internalized weight bias, weight stigma, and coexisting psychological disorders can significantly affect outcomes. These should be assessed directly and referral made when appropriate. Social determinants of health must also be incorporated into the evaluation. Health literacy, access to care, cultural beliefs, and patient priorities all influence treatment feasibility and success. These factors should be discussed openly and integrated into the care plan. After disease staging is complete, the next step is development of an individualized treatment plan. Treatment intensity should be guided by the stage of adiposity-based chronic disease and the number and severity of obesity-related diseases and complications. The goal is not maximal weight loss, but sufficient weight loss to meaningfully improve health outcomes and reduce disease burden. Treatment planning should incorporate patient goals, values, preferences, and access to care. Weight-promoting medications used for other conditions should be reviewed again and discontinued or substituted when feasible. Lifestyle and behavioral interventions should be individualized rather than standardized. Decisions regarding obesity medications and metabolic or bariatric surgery should be made through shared decision-making aligned with disease severity and patient preference. The final step is follow-up and long-term management. The objective of follow-up is optimization of long-term health and quality of life. Clinicians should manage the degree of weight loss needed to achieve therapeutic targets for improvement of obesity-related disease, monitor and manage medication side effects, and adjust therapy over time as clinical status evolves. Long-term treatment does not require use of the maximum approved dose of obesity medications. The optimal maintenance dose is the dose that balances effectiveness, safety, tolerability, and sustainability for the individual patient. This AACE clinical framework reframes obesity as a chronic disease driven by adiposity, diagnosed by anthropometric findings, staged by disease burden, and treated according to clinical severity rather than body weight alone. Today, we reframed obesity as what it truly is: an adiposity-based chronic disease, diagnosed by more than BMI, staged by disease burden, and treated according to clinical severity. The AACE framework shifts the focus from weight alone to health outcomes, individualized care, and long-term disease management. This approach allows us to treat obesity with the same precision, intention, and respect as any other chronic disease. This was another bite-sized episode of Endo in a Bite. In the next few episodes, we will be working through the details of the AACE consensus statement, the algorithm for the evaluation and treatment of adults with obesity or adiposity-based chronic disease, the 2025 update. Remember to visit www.easyendoprep.com to sign up for the weekly newsletter and have all the key pearls delivered straight to your inbox. You can also purchase the full board review course there for deeper learning and ABIM exam prep. Let's get through this document one bite at a time.